Hello and welcome to today's webinar, Telemedicine and COVID-19, supported by the American Academy of Neurology. It's led by faculty members Mr. David Evans, Dr. Karima Benammer, and Dr. Neil Busis. Mr. David Evans is the CEO of Texas Neurology. He is the chair of the AAN's Health Policy Subcommittee and past chair of the AAN's Practice Management and Technology Subcommittee. Dr. Karima Benammer is Assistant Professor at Emory University, the Chief Quality Officer of Neurology at Emory University, and a member of the AAN's Education Committee. Dr. Neil Busis is Associate Chair, Technology and Innovation, and Clinical Professor, Department of Neurology, Clinical Director of Clinical Affairs, Telehealth Program, NYU Langone Health. He's also the alternate CPT advisor for the AAN at AMA CPT editorial panel. Today's webinar will feature the following topics, including setting up telemedicine services, performing the neurologic exam, and coding the exam. We would like to note that CPT codes, descriptions, and all other data are copyright of the American Medical Association 2020, all rights reserved. CPT is also a trademark of the American Medical Association. And with that, I'd like to turn the presentation over to Mr. Evans.
Thank you, Becky. But just going to quickly take this moment to want to thank all of our frontline healthcare workers and all of our members from all settings. We understand many of the issues you're facing. We want you to know from the AN perspective that we have all dedicated 200 staff members looking at all angles, utilizing all of our different committees and levers to ensure that we're addressing as many issues as possible. And specifically to advocacy, I want to just highlight some of the areas specific to what the AN is doing and has done thus far. So by the end of this week, the AN will have sent 3 letters to the federal government on COVID-19, one to the Health and Human Services Secretary, Alex Azar, one to Congress, and another to Vice President Pence, as you know, who chairs the White House's Coronavirus Task Force. Additionally, HHS, if you follow the Capitol Hill report, you may know that the AN has seen for its leadership in its advocacy, and they actually reached out to the AN. Dr. Busis, who's co-presenting on today, actually was able to present to them on our telehealth initiative. So we're seen as a leader in that. We're hopeful that the information we'll provide today is helping not only in the advocacy angle, but help for you to be able to transition and implement this quickly in your organizations. Also, we've been highly recognized in media by WebMD, Medscape, Practical Neurology, Hospitalists, and Policy and Medicine. Other things, we know that many of you are facing unknown future for many of your practices in different settings. So I also just want to quickly run through other things that we're doing from the advocacy angle, letters that have been sent or will be sent in the next couple of days. And so just quickly run through those. So increase funding significantly, but beyond what is already appropriated for personal protective equipment, provide financial support to physicians who directly test, diagnose, and treat COVID-19. We've asked for suspending the Medicare sequestration cuts to physicians and hospitals, require and federally fund an increase in Medicaid payment rates for E&M services to match or exceed Medicare rates, provide dedicated financial supports to all physicians in their practices, experience adverse economic impact from delayed or canceled visits and procedures. We are requesting that CMS has the authority to reduce regulatory burdens and costs on healthcare practices to help physicians focus on providing necessary high-quality care to their patients, increase flexibility and support for telehealth expansion, including encouraging nationwide support for healthcare providers to practice across state lines, which we'll speak to a little bit today, including the ability to prescribe controlled substances during the state of emergency. Also asking for that to be expanded to include federally mandated or regulated ERISA plans, including the expansion to include coverage and payment for audio-only telehealth, especially since we're experiencing nationwide bandwidth issues, and we'll speak to that a little bit later in the slides. And again, we want that to be parity pay with an in-person visit during the COVID-19 crisis. Guaranteed payment and coverage parity for all medically necessary services provided via telehealth, and mandate that other payers adopt similar policies. We've worked and sending letters at the state level as well. We encourage you to reach out to your local state medical associations, but please know that the AAN has already worked through the National Governors Association, sent letters directly to each governor asking them to implement and enforce these policies at the at their own state level, so that all neurologists are protected in ensuring that they don't have an economic crisis on their hands on top of trying to deal with the patients that we have to do. Another one is we're asking for payers to waive prior authorization and utilization management until COVID-19. Personally, we'd like to see it longer, but those are some of the highlights of what we're doing. I want to move on to the seminar, but I want you to know behind the scenes, there are dedicated 200 staff. Beyond that, there are 6,800 member volunteers that work on behalf of the 36,000 members for the American Academy of Neurology. All have assembled, are working around the clock to make sure and look at every opportunity they can to ensure that behind there they are the unsung heroes that will work at your behest to make sure that you can focus on the front lines and hopefully that you can remain in practice and serve your patients. So what we want you to understand is that we're going to be speaking broadly about some of the federal applications, and want you to understand that much of what we're going to talk about is at the federal level, and we'll also speak to where you're going to need to speak a little bit more at the local level. So specific to Medicare, as you may know, that there has been some relaxing of the rules. So setting up telemedicine, and now we have designed this webinar in a way that you could continue doing telemedicine. I think it's a great opportunity. We have been advocating for the expansion of telemedicine for the past decade, and we're instrumental in getting several bills passed, including the Stroke Fast Act and other bills that were instrumental in the delivery of medicine via telehealth. But we see this as a good opportunity for practitioners to implement this in their practice. So with that, we'd prefer that you try to do it through a HIPAA compliant way. But again, we understand, and there is a relaxing of the HIPAA requirements. So we understand that as well. So some of the ones, and again, the AN does not endorse any one vendor. We've heard success of the ones that are listed here. Just want to give an overview on some that we're looking at. So Zoom. And again, I think a lot of these are offer a free version, but the Zoom paid version is about $200, I believe, a month. Doxy.me has a free version, $35 a month. Will give you a little bit higher quality. Video, I looked at the site today, and they're actually offering, there's a click on there for during the COVID-19 crisis that you'll actually be able to get it free during that as a healthcare provider. Go to the telehealth section and click on the COVID-19 crisis, and you can link on there. And my understanding that's an Epic integrated one. The other one is reach out to your vendors if you already have an EHR. There are some, obviously, some scales of efficiency if it's integrated in your EHR. But we also want to be sensitive to the issue that we are having a national bandwidth issue, and we will want to make sure that there are some contingencies in place to sort of understand that, what you do in those circumstances in the event that happens, and we'll be able to address those a little bit later today. So the other question we're getting a lot relates to if you need to proceed, or if you have a challenge with the visit, or if you want to proceed with a service such as like FaceTime or Skype. And so our answer to that, again, is best practice would be to try to go with a HIPAA compliant vendor. The general rule of thumb is if they can execute a business associate agreement, then they would most likely be able to comply with the Indian encryption and the requirements under the HIPAA requirements. I did check today, Skype does offer an execution of a business associate agreement under their E3. E as in Evans, I'll use that, and then E as in Evans in 5, so E3 or E5 platforms. FaceTime does not. There's a lot of debate on whether or not FaceTime is HIPAA compliant. I will tell you from the legal perspective, it is not. But again, we do have relaxed HIPAA requirements during the COVID-19 crisis. So you will not be fined during the COVID-19 crisis. So again, as a contingency, you can use these alternatives. You obviously can't use a public-facing video component or technology, but other than that, this is sort of our suggested route. So again, I already spoke to the HIPAA compliance. What the Health and Human Services Secretary is advising is that you use good faith use of telemedicine in regard to the HIPAA penalty. So obviously not a gross negligence or disregard for the patient. So obviously Dr. Banammer will speak to the consent, and I think if you are on either a low bandwidth or having difficulties on the audio video component, you want to make sure that the patient or you are able to conduct the visit, and maybe that's discussed at the consent to make sure that the patient is able to hear you and you can conduct the visit appropriately. If you need to, you can quickly switch over to a FaceTime if you need to or something during this unprecedented bandwidth issue that we're sort of experiencing as a contingency as well. We also want to make sure that we're providing information because there is a lot of misinformation out there, and much of this comes from because there's always this not necessarily coordination between federal law and the state laws, and specifically with the practice of medicine, we always have sort of this challenge between who's sort of in control with that. And the bottom line is the states control the practice of medicine. So although the HHS has sort of waived this portability of licensure, it really doesn't do much other than say what they're basically saying through that is, look, we're going to pay you if you practice in other states, but really the intent of that regulation was intended to help doctors that were facing acute care centers or hospitals that could quickly get over to other centers and do that. It was not entirely intended for telehealth visits. So we would suggest that if you are, not licensed and your patient is not in the state that you're in, or you're intending to provide, a high number of visits where your patient is not in the state that you're in and licensed in, that you should, number one, reach out to your medical board for guidance or see if they've issued a state waiver. And then again, on the next bullet point is a couple things. One is many states require that there's a mandated form that states will require for the performing of televisits. I can only speak to Texas and my insurer. They have proactively waived that requirement, but if you have not received anything proactively, put that on your checklist today to make sure that you reach out to your malpractice carrier to see, number one, if there is a mandated form, if that's required. If it is, make sure you get that completed and on record. But I also see where there is not a state mandated form that many malpractice carriers do want you to have a current list of services you're performing and whether or not you're providing care in a different mode, and telehealth would fall in that category. So I would highly suggest that you reach out to your malpractice carrier. And again, crossing of state lines, what I would say is you practice only in the state that you are licensed in, and your patient should be located physically during the visit in the state that you're licensed in. So again, there's a little bit of confusion here, and we want to make sure that this gets clarified from CMS. And again, we're speaking specifically CMS, and we're going to speak a little bit later, but also about the local payers. We want you to make sure and navigate this appropriately. We are constantly updating the AN.com/telehealth resource guide, and that's going to be a good source of information, but you're really going to have to look at your local payers and make sure you get some good information. So what basically the HHS said is that under the current televisit rule, there are two components that were of concern. One is that the patient had to be basically at another healthcare provider site. They have waived that component. So basically now the patient can be at their home. Back to they should be in the state you're licensed, but they can be at their home in that state that you're licensed. The other is they had to be an established patient. So CMS or HHS has not waived, they have not said that we are removing that rule. They just said we will not audit that rule. Could not be more confusing. So what they have said is, look, we're not going to audit, we're not going to penalize you if it's a new patient perform the visit, but we just won't audit you for it. But we're not going to change our rules. With that, though, you still need to look at your state rules. So, for instance, like in Texas, we do have a requirement that we cannot initiate a televisit with the patient unless they're established. Now, immediately we worked, and actually some of this work was done through the initiatives that the AN led at the state levels, is that we immediately saw our governor respond to some of these letters that were coming through and immediately waived the requirement of the patient's requirement or the state's requirement of the patient being new to the provider. So that has been waived in some states, but again, you'd want to check what I found the two best resources are your state medical association, but I've really been impressed with two others that I rarely see these kind of informational updates, and that is the medical board's websites, and the others, which rarely you see information that's even barely useful, is the Department of Insurance sites are very useful because they want to make sure that not only that the department, the insurers that they're regulating are complying with the mandates that are being applied to them in regards to parity pay, that the providers are understanding the difference between the state-regulated ERISA plans, the Medicare Advantage plans, and they're making sure that those things are well navigated through. So put those on your bookmarks and make sure that you have that information available. Again, another option available. And again, I think this one, you can waive the co-share amount from the patient side. That's up to you whether you do at the practice level. I think from my perspective, and we're in private practice, where I sort of advised our providers to sort of use this is if the patient's hesitant or if the patient is like, I'm not getting my bang for my buck, or I just whatever, and they are a high risk patient, and you're just advising that they shouldn't come in the office. That may be something you want to use that sort of lever and say, look, we're going to make sure we'll waive your copay for that. I mean, I'm not advising that, the AN's not advising that, but you may want to consider how can you use this to make sure. And we're in a private practice. I get the economic restraints, and we're looking at that at the AN on making sure that the federal government's budget planning and expansion planning that they're looking at doing is having dollars reserved to help sustain our practices. The Small Business Administration does have dedicated funding to help for the economic relief. But these are things I think we have to sort of navigate now. We really need to think these things through, and we need to help guide our schedulers, our medical assistants, and all those in how they navigate those things. Again, you really need to check with your local payers on anything beyond the Medicare guidance, which could not be more clear, and that is surprising. I mean, one thing we do like with Medicare is they are very clear. They take legalese to another step, but then they bring it down to a level we can understand, but we can at least dissect it, implement it. We know what to do. We can follow it easily. The other payers, I think, are a little bit behind the 8 ball right now, which is why we're trying to pull the lever with the governors to mandate it. They're still going to be a little bit behind, but I think we want to make sure all those things are available. So again, some other recommendations, and again, I'm looking at this from a private practice perspective, but how are we utilizing our staff? We're looking at, reducing hours, maximizing our staff utilization, and how we use our staff in different creative ways when you got a hybrid televisit visit. So one of the first things we do is we pull our cancellation and no-show list. We have the medical assistants sort of repurpose. They're calling all those patients to see why they canceled, offering televisits. Obviously, incoming calls, they're offering both televisit or rescheduling as appropriate based on how they're either triaging those calls or based on the instructions we've given them. Other things they can be doing is sort of assisting on the back end to support the healthcare providers in preparing for televisit. So prepare like a simple guide. I think one of the things we can work through practice management technology is maybe a simple guide. We're doing one in our office. I'm happy to share it, and we could provide it so you could repurpose this in your organization. We're going to have ours based on doxy.me, but you could simply do it, have some simple workflow, implement it throughout your office, and then hopefully be a simple guide that you can repurpose in your own center. But basically, we give guidance on download this. Here's what you need to prepare the visit. Hopefully, you're utilizing your portal so that patients can get some of the information or go in before the televisit and complete some questionnaires. But if not, they could schedule a time with the medical assistant to obtain like past medical, social, surgical history, do medication reconciliation and document review of systems. They can also prepare the patient for the provider and test connectivity issues. Thank you, Dr. Banammer.
Thank you, David. Hi, everybody. I'm Karima Banammer. I am a neurologist and a neurohospitalist at Emory University. And I've been doing teleneurology for a couple years now, but mainly on the inpatient side since I'm a neurohospitalist. Of course, we've all been thrust into this due to the COVID-19 crisis. And so I just wanted to share some tips about how I kind of learned through practicing it, really, what would be best practices for teleneurology. So I think that what's most helpful is to remember that or to consider it as an in-person visit. So you want your exam room to be private. You want to ensure that your patient knows that this is a visit between you and the patient and that there are no privacy issues there. Your acoustics, you don't want to have honking or, cars behind you or a dog barking or that kind of thing. I mean, it's okay every now and then to have a dog barking, but you do want to have, a proper setup. The lighting, you want to make sure that your light source is in front of you rather than behind you. So if you're sitting and you have a window behind you, you want to close those curtains because that will otherwise shadow your face and the patient can't have a good visual of you. You want your interior surfaces to be neat and, you could use a desk or, but, not too cluttered so it doesn't take away from the actual visit. And then as far as equipment, you really can use anything. It can be a computer, a phone, or a tablet, as long as you have a high quality video and high quality microphone, integrated microphone and speaker in them. If you don't have, and most of these things do have integrated microphones and cameras. If your camera is not high definition enough, then you could use an external camera, or if your microphone, has a problem, then you could use an external microphone so you can have a high quality one. Sometimes you can use headphones to try to, eliminate echoes and kind of the outside background noise. And you want to make sure that you have a high-speed internet connection. So you want to make sure that it's at least over 3 megabytes per second, and you can easily test your speed, your internet speed connection just through using, for example, Google Speed Tester. There are many testers out there. So when you start your teleconsult, you want to, just as you would check your patient information, you want to make sure that you have proper identifier with your patient. You want to use a two-factor identifier, so name, last name, date of birth, that kind of thing, and put that in your note. It is imperative to have consent for all telehealth visits, and the consent can be obtained either by your support staff prior to starting the telehealth visit, or you can actually obtain it yourself by, verbally talking to the patient and explaining to them that this is going to be an audio video or audio only, what have you, and if they consent to continue with this, and do document that in your note. There are some things that I'd like to just share tips on how to perform a neurological exam through video that I found helpful. A lot of people think that the tele exam is very limited because you can't do reflexes and you can't do this and that, and it's true that there are some things that are limited in a tele exam, but you'd be surprised at how much you can actually obtain. So a lot of people have blood pressure cuffs at home. So you can easily tell them to obtain their blood pressure and mark that, and their heart rate, and mark that under your vital signs. So whatever is on the slides is in green means it's easily obtainable, and whatever is in orange means it's possible, but you just need extra steps for that. So for example, the vital signs, you need your patient to have a blood pressure cuff at home, for example. Your mental status, you know, you can easily assess whether the patient is alert and oriented ×3 or not. You can give 3 items or 5 items for recent and remote memory. And you can actually even perform an entire MOCA if you use the blind version of the MOCA. And I have a picture of it here and the link to go to it. But so the only things that it doesn't have is, you know, the trails and the naming, the animals. But other than that, so you can score out of 22 rather than out of 30 and get a pretty reasonable cognitive assessment. Your language, you can test your reception by asking them to do midline commands, cross midline commands, and then, you know, naming and repetition, obviously, it would be easy to do. Your cranial nerves, so, you know, so there is this entire field of tele-ophthalmology that now actually exists, where you can get a fundoscopic exam. There are some apps out there that are integrated that you can download on smartphones and that have even been looked at by the FDA. Some are FDA exempt, some are FDA approved. And so I have a list here from a paper that I found in Advances in Ophthalmology and Optometry that was just published last year. Of course, it may be limited compared to your usual fundus exam that you would do if you were a neuro-ophthalmologist, for example, but that is actually an option that does exist. Some platforms would allow you to zoom very close and actually be able to do a pupillary reflex. So we've used 3 platforms now so far at Emory, and when we used to have video, I used to have a camera where I could zoom in on the patient and just ask the nurse on the other side to shine a light and evaluate the pupils. Your extraocular movements, you can just ask the patient, you know, to look left and right, and you can see whether there are any restrictions in eye movements. Face sensation, you can have a tele examiner on the other side or have the patient touch on both sides or a family member. Face movements, you can ask them to close their eyes, puff their cheeks, purse their lips, things like that. And then hearing, you know, very easily, you can measure that with the rub of a finger with an examiner on the other side, or if the patient is at home, just ask them to rub their fingers and see if they're here on the same way on both sides. Like I said, the camera, you can have some zooming cameras where you can see palate elevation, and then shoulder shrug and tongue would be easily seen. So motor exam, what is limited is that you can, if you are examining a patient at home, for example, and you don't have a tele-examiner on the other side, you could probably not get a, you know, a full strength peripheral neuromuscular exam. But you can actually easily assess for mild weakness by just doing, you know, regular procedures like what we would do, the pronator drift. So I added pictures here of the Barré maneuver. Barré was actually the French neurologist that you all know had described Guillain-Barré syndrome. Before that, he had actually described the pronator drift, and these are pictures of his original publication in 1913. And so you can ask the patient to either have their arms outstretched in front of them and close their eyes, and you will see a drift. You can also tap on the hand, and that can, if there is pathological weakness, it will bring out the drift even more. As far as lower extremity strength, the Mengazzini maneuver can also be used. So you could either ask the patient to lift their entire leg and see if you can see drift, or if you wanted to get rid of the, you know, iliopsoas component to it, you could actually just ask them to do what's shown here in the picture, where they just flex the hip and then just lift, keep the legs at 90 degrees, and you could easily see weakness. Sensation with the help of a family member or a parent or an examiner is easily done, and you can do light touch and temperature. Coordination, you can have them touch an examiner, then touch their nose, or if you don't have an examiner on the other side, if the patient is at home, you can just have them outstretch their arm all the way and then come back to their nose, and you can see if there's any dysmetria. And gait and station, you know, as long as you have a good angle where you can see the patient in an uncluttered space, you can definitely make them walk. You can make them stand on one leg, which actually also gives you an idea of whether there is leg weakness, things like that. Reflexes are in orange because they would be difficult to do unless you have a nurse on the other side. If you're doing the telehealth visit, you know, in a clinic, for example, you can definitely not do it with somebody who's at home. And Dr. Busis was telling me yesterday or the day before yesterday that he's had no problem getting plantar reflexes and looking for a Babinski sign. I personally have not done that. Like I said, you can actually obtain a lot of things with a tele-neurological exam. The only things that would be really limited would be, for example, a vestibular test. You can't do a Hintz exam. You can't do a Dix-Hallpike. Like I said, the different neuromuscular components would be hard to do unless you have a skilled examiner on the other side, so not at home, and then a comprehensive eye exam. As far as prescribing medications, you also want to prescribe as you normally would, so you can e-prescribe. In the past, you were not allowed to prescribe restricted substances, and that included opiates, benzos, and even some anti-epileptic medications. However, just last week, the DEA waived all of that, and as long as you have legitimate medical purpose, you know, treating epilepsy or pain or things like that, and you document that, then there will be no problems with prescribing. You still want to comply with your PMP and, you know, do your due diligence just as you would in an office visit.
So we'll now talk about coding the visit. As I'm sure almost everyone, if not everyone on the call understands, visits are coded by diagnosis and by what you've done. And in most cases, what you've done is coded by CPT codes, which stands for current procedural terminology. The rules, as we'll discuss, are really very similar to what you do for in-person visits. We'll talk about some of the differences. And we also want to make you aware that under certain circumstances, CMS wants different codes than CPT codes. And for the purposes of services and procedures, they set up G codes. And so we will see some G codes that are either substitutes for CPT codes for various technical reasons or describing separate services. So we will talk about both CPT codes and G codes. Just like CPT coding for an in-person visit, you have to ask some questions to determine the correct code and then the correct level. So are you using video or not? A true telemedicine encounter in the fullest sense is audio and video. Is the encounter real time, which in CPT language and G code language is synchronous, or not? You know, are you interacting with the patient right then and there or separated in time like email? Is the patient new or established? And as you heard from Mr. Evans, they say telemedicine is for established patients, except we're not going to audit. And in the case of some codes for stroke patients, et cetera, they can be new patients, and we'll talk about that later. And outpatient or inpatient. CPT codes are more flexible in terms of telemedicine coding if they're outpatient and inpatient. And that's one of the reasons that CMS has made G codes for new inpatients. And once again, remember that the place of service is where the patient is, not where you are, but where the patient is. And one of the major advances in this recent pandemic and public health emergency is that the place of service can now be at the patient's home. They don't have to be in a medical facility. Medicare and Medicaid at a very, very high level. And you may find some of the terminology confusing, and I would like to try to explain it to you. Medicare talks about 3 different kinds of remote care services. There are Medicare telehealth visits, and these are basically evaluation and management codes, which have the same elements, history, physical, medical decision-making, time, as the ones that we're used to for in-person visits. And then they talk about 2 other kinds of codes. Virtual check-ins, which are brief visits that are linked in a certain way, which I'll explain, to previous or future E&M visits. And then e-visits, which are basically digital evaluation and management codes. And we're going to talk about all of these except for the e-visits, which are done by providers who are not licensed to provide E&M services. So those G codes at the very bottom we won't consider, but we'll talk about all the other codes. Medicaid has traditionally been the most open to telehealth of all of the payers, but it varies by state. A call has gone out because of the global pandemic and public health emergency to liberalize Medicaid policies, and this is happening at a rapid rate, but there is tremendous variation from state to state. And some states, such as New York, where I'm residing right now, just developed brand new telehealth regulations, much more liberal than before. They came out on March 23rd. So stay tuned. If it hasn't happened in your state, it may happen in the near future. Many people may not have computers or smartphones, but almost everybody has a telephone. And as you'll see, we can now get reimbursed for telephone visits. The codes used for Medicaid are the CPT codes in the book, which are on this slide. And then we're not ready to go to the next slide, but the next slide will show you the ones that are covered by the other payers. There are 3 different telephone E&M services in the book, 4.1, 4.2, and 4.3, and they differ by time. They're time-based codes, and they have a couple of catches to them. They have to be initiated by the patient, and the telephone consultation has to be done by someone who can provide evaluation management services. So if you are a medical assistant or secretary or somebody calls them, that doesn't count. The other thing that's tricky about them is that they are linked to previous and future evaluation and management services in person. So if this call that you're making is related to an evaluation management service within the last 7 days, it's lumped into the post-service work of that evaluation management service and cannot be billed separately. If it leads to an E&M service in person or a procedure within the next 24 hours or the soonest available appointment, it is considered the pre-service work of that in face-to-face evaluation management service. So if it's separate from previous one by 7 days and doesn't lead to something soon after, it can be billed separately. 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes are the 3 levels. One of the virtual check-in codes from Medicare, G2012, is basically analogous with the lowest level of telephone code, but it is covered by Medicare and the commercial payers. They do not cover the CPT codes, they only cover this G code. And you'll notice that because it's only 5 to 10 minutes, they don't really cover anything longer than that by telephone. And the rules about timing of E&M services 7 days before, 24 hours, or as soon as available after, are exactly the same. These codes are called online digital evaluation management services. And as compared to the telephone codes, which we talked about, and the traditional E&M services, which can be modified for use with telehealth, are actually quite complicated to use. They are for periods of up to 7 days, with the clock ticking when you, the provider, review the patient's request for evaluation established through a HIPAA compliant patient portal. And all of the efforts that you do for that 7 days, replying to the patient, looking at data, discussing with clinical staff, etc., goes into that time. So there are questions about how you track this over 7 days. They have 5 to 10 minutes, 11 to 20 minutes, and 21 or more minutes. They can't be billed with the chronic care management codes, which they sort of overlap with. And they're kind of tricky because if they are related to an E&M service 7 days before, just like the telephone codes, or are related to an E&M service in person 7 days later, they are considered post-service or pre-service work. So institutions have some hard times figuring out how to implement these, even though they're potentially promising codes. So they are asynchronous, but complicated timing and measurement. G2010 is a virtual check-in code, and it's actually a much simpler digital evaluation management service because it's basically a single episode. It's remote evaluation of some data, video or images submitted by an established patient, and you're supposed to follow them up with what you think within 24 hours. But they have the same kind of caveats about E&M services 7 days before and 24 hours later, like the telephone codes. So you look at the image or video, and then you have to communicate with the patient. If you can't actually look at the video because it's poor quality, then you can't bill for it. This is covered by Medicare. We now move in the last two slides of this section into more familiar territory, which is basically evaluation and management codes as we know them, except they're delivered by telehealth. So CMS decided that they would not use modifiers with inpatient CPT codes that are in the manual, and instead they would use G codes. They have 3 G codes for initial visit, 3 G codes for subsequent visit, and they have time with them, elements with them, etc. The ones that we will probably use much more are the outpatient E&M codes. And the codes that can be delivered via telemedicine that we also can deliver in person are listed in Appendix P of the CPT manual. There are a whole bunch of codes there. Many of them are not relevant to us, such as renal service, behavioral health, etc. But the new and established office visit codes and the hospital follow-up codes, which are the ones across the top there, are ones that can be delivered by telehealth. The rules are exactly the same as what we've been teaching for in-person visits for years. You determine the level by elements or time. If you are reporting to Medicare, you use modifier 95. If you are reporting to commercial insurers, you are using modifier GT. And as Dr. Banammer mentioned, because of some limits of what you can do in most teleneurology consultations, the highest levels, which require 23 elements of a comprehensive neuro exam, can't be achieved because you probably can't get to 23. It's very difficult to look in someone's eyes. Most people don't have that equipment. There are vital signs issues, etc. So for the highest levels, you will be able to get there by time. And for the lower levels, you will be able to get there by time and by elements.
Dr. Busis, I'm going to ask a quick question on the modifiers. Can you clarify which modifier for the Medicare Advantage plans? Because that is a common question by the members. If you can just clarify that.
The answer is I actually don't know. I know that our guidance is Medicare for modifier 95. I don't know whether it's going to be 95 or GT for Medicare Advantage. What we'll have to do is have the staff look into that, and then we can post something on the website. That's a great question. Thank you.
Okay, we'll follow up on that. Thanks.
Thank you so much. We want to thank our faculty for that overview of telemedicine. We'd like to mention the additional resources that the AAN has put together. Please visit aan.com/telehealth and aan.com/COVID-19 for additional information. We will now move on to the Q&A portion of the webinar. For questions that we don't get to, we will be compiling an FAQ and publishing it on aan.com in the coming days. So one that came in out to the panel: has the requirement for provider's location, clinic site, been waived? Specifically, can the service be performed from the home of the provider, and do you have to be in the U.S. to perform teleneurology?
I believe that it doesn't matter where you are, it matters where the patient is.
I concur.
Okay. Can you elaborate on the malpractice issues of telemedicine? The physical exam is limited under telemedicine and important signs may be missed with potential effects on patient outcomes. What exactly can be comfortably performed via telemedicine?
You want to make sure that you clearly state things that you are unable to do. You don't want to be guessing. If you don't have a good visual on your video, or if it's a phone visit, for example, you definitely want to state that, exam limited, so you cover yourself.
Yeah. I would add to that. When you think about telehealth, you have to put it in context of all the other services that we perform. And there are some things that you can perform and you say, I am confident that this is what I need to do, and I've done it. There may be other situations, either due to bandwidth issues or exam issues, things you can't do, where you say, this really has to be considered a triage session, and for this patient to be more fully evaluated, they have to be seen in person by yourself or by somebody else. And I think that should be stated clearly in the note. We have had patients that we've transferred from one hospital to another hospital, for example, because we said we didn't have the in-person neurologist at the other hospital to evaluate them, and they had to be seen in person.
Okay, another question for Dr. Benammer. Does patient consent need to be written to, or is it verbal sufficient?
So verbal is sufficient for the most part. However, there are some states that are more that have extra steps, and you want to check your state. So the website for that would be cchpca.org.
And we do have a link to that on our telehealth website as well.
Yeah, and one thing we've been able to do is repurpose our patient portal so that one of the questions the patient asks is we link to terms and conditions on our website, and then they affirm that or attest that they read it. And that's one way that you can do and meet that written attesting. But again, check your state requirement.
And a question for Dr. Busis just came in. When documenting the encounter, should the start and stop time be noted, or is a comment of 11 minutes were spent discussing with patients sufficient?
So this is a great question. And it turns out I had the opportunity to ask a CMS representative about what the CMS attestation statement requirements are. This, of course, is not other commercial insurers. In our HHS call earlier this week. And believe it or not, there is no universal attestation statement. And it depends on the insurer, the Medicare carrier in your state, the commercial insurer, et cetera. So there is no single answer to that, but if you are going to bill by time, clearly you will have to include time in your note somewhere. If you are going to code by elements, at both institutions I've done telemedicine at, we have not felt the need to document time unless you're billing by time. I hope that answers the question.
Yeah. Dr. Benammer, do I need to save audio video visits into the EHR or just document in one written note?
Yeah, you do not need to take screenshots, record videos, none of that. You just need to write your note like you would in an in-person visit.
And Dr. Busis, how do I bill and document for incident to billing for a telemedicine visit?
So incident to billing is really about the same as an in-person visit. If you are in the same facility as your PA, NP, et cetera, and available, that's fine. If you're not, then they will bill under their own NPI number. The rules are really the same as with incident to with face-to-face visits.
Sure. And Mr. Evans, what can practices do to standardize and troubleshoot a telemedicine visit?
Yeah, so one of the things we're working on right now is updating our guidance on our website. And actually, when I send out the our workflow guide, when we send out the webinar information, I'll send our link, and hopefully people can use that as a repurposed guide. But again, we're utilizing staff to test the equipment prior to the provider entering that, just to keep the providers staying on schedule for the day.
Okay. And Dr. Busis, are the new versus established patient rules the same for telemedicine, meaning the Medicare 3-year rule?
Yes, they are officially, but as Mr. Evans emphasized, they're not auditing.
And another one for Dr. Busis. If video fails midway through a visit and visit is continued over the phone, how should I report the service?
That happens a lot, and I've done a lot of thinking about this. And in discussions with other providers, it's sort of like when you supervise a resident in person. If you feel that the key components of the exam could be accomplished before the video failed, then I think you can bill for an audio and video visit. So for example, I've had case I finished the exam and then all of a sudden the video goes out and I can still talk to them. I've done what I need to do by eyesight, and I don't feel any problems in documenting that as a full telemedicine visit.
Dr. Banammer, can I perform new patient consults via telemedicine?
Yes. The short answer is yes, you can.
Okay. Another one for Dr. Banammer. Can you talk about prescribing medications for my patient who is now out of state? I have an epilepsy patient who has moved to another state and due to COVID has not been able to find another neurologist. Can I prescribe her AED?
Yes, so you can practice now across state lines. I was told that so the general rule is for telehealth, now you can practice across state lines. I was told that there are some states, I think Alabama was one of them, that did not allow this. So you just don't want to double check with your state, but the federal rule is that you can practice across state lines and you can prescribe as well across state lines.
And Dr. Busis or Mr. Evans, do you know if all commercial payers are allowing for and covering telemedicine?
So the short answer is no. What we would highly suggest is that you should monitor if you go to the links on the AAN's telehealth guide, start there with the link to the American Health Insurance plans, reach out to your local plans, your state medical association, if you don't have a mandate from your governor, and then your payer websites. Also realize that it can get complicated in that some plans, it could be down to the plan level, whether it's an ERISA plan, which gets very complex. What we've been doing is creating sort of a worksheet, and then we immediately stopped because our governor issued a mandate for parity pay, so we stopped that immediately. But we had started sort of a spreadsheet to sort of track it. Very complex, so we'd like to see governors in all states mandate that. But you would need to check the payer and the plan to see whether or not allowing that.
Great, thank you. And Dr. Busis, am I able to bill a level 4 and 5?
Yes. So basically, we've gone over this in great detail. And so the answer is different depending on whether you're talking about new or established. If you look at the outpatient world, we've figured out that since you need a comprehensive neuro exam with all 23 elements, you will not be able to get a level 4 or 5 new patient by elements alone because you need 3 out of 3. History, physical, medical decision-making, but you can do it by time, which is 45 or 60 minutes. In terms of established patients, you can do it either by elements or time for level 4. Remember, established patients are 2 out of 3 elements, history, physical, and exam. So frankly, you don't need to examine them at all, although that's probably not good medicine, or by time. And for level 5 established, you can still do that because though you can't do the full exam. So the answer is yes, time for level 4 and 5 new, and either one depending on how you configure it for the established patients.
Okay, we've got one final question directed at Mr. Evans, but the rest of the panel can chime in too. Some of my patients do not have FaceTime on their phone or access to any other video technology. Is my only option a telephone visit?
Oh, I'm going to hand that to Dr. Busis, actually. That's a coding question.
You know, I want to jump in. I just saw, maybe Dr. Busis was you who sent that, but I saw that a recent study by Teledoc showed that only 16% of people, including elderly, did not have access to, you know, the technology. So I used to think that that was a big problem, but it turns out that it's not. Go ahead.
There's really two, that's an excellent point. There's really sort of two parts to this, okay? One is, do you have it? And two, can you use it? We have found in our direct-to-patient model of telemedicine that good news is patient has smartphone, maybe downloaded app, but doesn't know how to work app. So there's a lot of patient education involved, even if they have the equipment. And I like very much what David Evans said about when the visit is being scheduled, to have someone check out and make sure that the system works before you even schedule the visit, because we've had some visits in places where telemedicine has been rolled out relatively recently, where a lot of the visit is actually doing tech support. And so you either have a choice of completing the visit and then being late for the next patient, or not completing it. So just because they have one doesn't mean they can use it. And so one of the big lifts, I think, in telemedicine now that's being widely rolled out across the country is patient education. No matter what platform you're using, the only exception to that is in an inpatient setting where there's a telemedicine cart and a dedicated telepresenter. That person, by definition, knows how to use the equipment and do the troubleshooting. But when you're having patients operate their own devices, it's certainly possible, but it takes a fair amount of patient education with some patients.
Yeah, no, I will say we do screen all patients to ask them about their technology capabilities, and as soon as we ask them about another family member or a caregiver, we always identify that. So we have not had an issue at the practice level or with any patient who's not had the technology or that kind of ability to handle it. They've been able to identify, including with all of our patients register and fill out their information through our portal. We help them identifying a caregiver that can help them in proxy, and that's a good advice for that.
All right, I'll jump in and thank you so much. We're at time. That will conclude today's webinar. On behalf of the AAN, I'd like to thank our faculty members, Mr. Evans, Dr. Benammer, and Dr. Busis. I know there are several questions that we did not get to, so as I mentioned before, we're compiling a list of these questions and their answers, and we'll post an FAQ on aan.com/telehealth. Don't forget, you can also send all of your practice management and coding questions to our experts by emailing practice@aan.com. Thank you.